Professor Bankole is in another meeting. He sent me a message to just kick things off, and then he would join us. So welcome everyone. Good morning, good afternoon, depending where you're joining from. This is our grand round for Neuro-Intervention, hosted by the Lagos University Hospital as well as the West African Stroke Initiative. On behalf of Professor Bankole, who's the consultant neurosurgeon at the Lagos University Teaching Hospital, I will be introducing the meeting and our guest speaker for today. I serve as an assistant professor of neurosurgery at the New York Medical College, and also an attending neurosurgeon and endovascular neurointerventionalist at the Westchester Medical Center, as well as the CEO of West Africa Stroke Initiative. We will give a few minutes for people to settle in, but we're delighted that you are here to join us for the grand rounds. We have several stakeholders from various parts of the world joining us today, including neurosurgeons, radiologists, neurologists, nurses, technologists, hospital administrators at Luth, in Lagoon, other hospitals. But we're trying to put together these grand rounds on a bi-monthly basis. So the title of today's grand round is ICU Management in Neuro-Intervention. A very, very important topic as we deal with patients that need neuro-intervention. The aftercare is as important, if not more important, than even the procedure, because you do very great procedures, but you don't get good aftercare, then we get very poor outcomes, which is undesirable. So here before us, I will introduce our guest speaker. Just before I do that, I want to ask that you mute your phones, your microphones, until you're called upon by the moderator or presenter, so we don't have echoing or distraction. We also say, please be careful when sharing your video. Be mindful of what's your background, because everybody can see it. We expect there may be a few technological hiccups, but we're hoping that it should be smooth today. Feel free to post your questions during the session as well. And there's a chat box. Feel free to put your questions up there. And either during the session of the presentation or afterwards, we can take those, our presenter will take the questions and answers as well. Very quickly, would like to present Dr. Ifeanyi Obi Iwuchukwu. He is a neurointerventionist at the Ochsner Medical Center and a neurointerventional surgeon at the Palmetto General Hospital in Florida. He received his medical degree from the University of Nigeria, Nsukka, a very prestigious university, I might say. Then completed internal medicine internship at the Long Island College of Medicine, SUNY Downstate, Brooklyn, New York. Dr. Iwuchukwu also underwent neurology residency at the Seton Hall University, New Jersey, Neuroscience Institute at the JFK Medical Center, Edison, New York. He did his fellowship in neurocritical care at the University of Chicago, Illinois. He also obtained a fellowship in interventional neurology from Palmetto General Hospital in Florida. So he's double-boarded, if not triple-boarded. Dr. Iwuchukwu is certified by the American Board of Psychiatry, and Neurology, and the UCNS Neurocritical Care. Assistant professor, the Department of Neurology, University of Miami, and a senior lecturer at the Ochsner Clinical School in affiliation with the University of Queensland, Australia. Dr. Iwuchukwu is a reviewer of several journals, including Stroke Journal, Neurology Journal, and Journal of Neuro-Interventional Surgery. He has published many research papers and clinical trials in reputable medical journals. We're not finished yet. He was a chair of the Neuroscience Research Board and Director of Research, Neurocritical Care and Acute Stroke at the Ochsner Medical Center, among others. He also held the position as a system-wide vice chair of the Neurocritical Care Department at Ochsner Clinical Foundation. He is involved in several global health programs and initiatives, and he is a recipient of several awards from different institutions, including the NIH. So we're very privileged and to invite Dr. Iwuchukwu to give us the talk for today. Thank you so much. Over to you, sir.
Just want to make sure I'm not muted.
We can hear you.
Okay, excellent. Yeah, thank you so much. That's very heartwarming. I appreciate the introduction. I chose to approach this talk more from a pragmatic or practical perspective. The context of trying to focus more on a very important question: what would I do with a patient I receive in the ICU after a neurointerventional procedure? So I have no disclosures, and content will circle around elective and emergency interventional procedures. Some key areas that I will highlight a lot: access side, meaning where the surgery, how they accessed for the procedure. Neuromonitoring, we'll dive into that a bit to have some insight. Blood pressure management, amongst other medical issues, and very importantly, a bone of contention that is always relevant in this field, the use of antithrombotics, when to stop, when to initiate, or when to continue. Some of the procedures that we do frequently, both elective and emergencies, as you can see, I'm sure everybody is aware of most of these, and the list continues to grow. I think in a recent conference, they talked about doing shunting through neurointerventional procedures. So this is, I guarantee this list is going to be obsolete very soon, probably in the next year or two. So let's jump in real quickly. So there are fundamentally three common access sites for neurointerventional procedures that are utilized. And I just want to make sure that everybody understands what we're talking about here. So most of this is related to endovascular procedures. Endovascular meaning accessing through a blood vessel, usually the artery, sometimes the vein. And typically we go through the femoral, the radial, or direct carotid puncture. Recently, radial access is becoming very popular. And mostly because it tends to have a slightly lower morbidity. The only challenge with radial access is that the tools that we have are kind of designed for femoral, so we're kind of improvising. So it takes a little bit of a hang. So it's not very common in some quarters, but in the popularity is gradually growing. And the reason we make this distinction between the different sites is that they have unique problems. And when I say unique problems, I mean especially for not just the proceduralist, but also for the person who takes over the patient once they come out of the IR or OR. So things like bleeding, ischemia, vessel injury with dissections, so aneurysms, and very important infections as well can happen in this, depending on the site. So the most common site that we use is the femoral access site, and the cannulation is you want to isolate the femoral artery and you want to be able to cannulate it. Preferably when you try to, usually you do use an ultrasound, but in some cases you go manual palpation and you want to feel for the femoral head because that helps you when you want to control bleeding or maintain manual pressure. Some things to always consider when you have a patient who comes out of the IR suite after a procedure is some of the questions you want to ask is, okay, so what happened? How did you close after the surgery? Was it difficult to close? Did it bleed? Was there any challenges with keeping the patient's leg immobile? Because trust me, once you're done with a procedure, the patient wakes up, the first thing you want to do is to move your leg. And movement of the leg causes more problems because the vessel that you've closed off the puncture site will pop open and could start bleeding. And then if you see that a patient comes in with knee restraints, don't be the smart person to just take out the knee immobilizer because that could just create a problem for you. And definitely don't ask them to start doing frog jumps once they come out because you want them to exercise. So there are other things that you really want to pay attention to is when they come to the ICU, you want to look at the groin and ask, hey, is this groin soft? Is it firm? Is there a palpable mass? Can you feel the pulses along? And because once you start having those signs, then it tells you that there is either a hematoma forming over the site of the puncture site. And you then have to worry, because at that point, if you lose your pulses, and then you run the risk of, limb ischemia, and then you start to see discoloration of the leg, and then that whole crisis comes up. And obviously, we have to always focus about the patient and not just about what we do. We have to think about if they're uncomfortable, if they're in pain, and then you want to also manage that. And don't forget that the femoral nerve is nearby. So more often than not, during the procedure, there could be injury damage to the femoral nerve. So look for those signs, especially if there are evidence of, leg weakness or leg numbness. So some of those things are things to pay attention to when the patient is in the ICU. A very common and very annoying problem is hematoma after femoral puncture site. It's one of the reasons why it is not, people are looking for alternatives. And there are two major types of hematoma I worry about in the ICU. Number one is the groin hematoma, and the other one is retroperitoneal hematoma. In both cases, the way it will present more often than not is hemodynamic instability. And then you also see obviously a mass in the groin. In retroperitoneal hematoma, you actually have no idea. The patient just continues to have mains tachycardic, hypotensive, you see the lactic acid is climbing up. And the way the groin hematomas present could actually be very similar to the way a femoral fracture, where there is avulsion of the femoral artery, will present. And the approach and management is you have to aggressively resuscitate these patients, because in both circumstances, liters of blood could be lost instantly. And the take-home message that I really want us to emphasize here is you have to look for it. You always have to be very agilely looking for it, making sure that you don't miss it. Because if you catch it early, then you can actually prevent it. You can actually prevent it from getting bad. And that's what you really want to accomplish. And that's where the concepts of groin checks after post-procedural care becomes very important. Usually this happens in the recovery room, but I won't be saying this if I haven't seen a lot of this in the neuro ICU after probably a wonderfully placed carotid stent or wonderfully placed flow diverter in an aneurysm. And in some cases, we've lost patients because of that. So like I was saying, early recognition is invaluable. And one of the practical components here is it is imperative that somebody looks at the groin at least for the first 1 to 2 hours after the procedure. If it is done every 15 minutes, that is fine. If there are any concerns of oozing, then it becomes very important that, first of all, you want to feel for a pulse. If you feel the femoral pulse, then you're ahead of it. And then you want to put your index finger and your middle finger over the puncture site, with a puncture site in between the two fingers, and then you push all the way down and compress it, so that way you occlude the vessel and at least give the tissue or the artery an opportunity to seal off the vessel naturally. And the rule of thumb is, at minimum, you want to hold that pressure for 20 minutes. It sounds easy, but I promise you, as a fellow, the first 6 months of fellowship, you generate a lot of muscle, like your forearm muscles are going to be big. I think my forearm became like 10 centimeters wider, just because you're holding pressure for 20 minutes and you can't lift off. So, and I can't tell you how important this is, especially in our environment, where some of those closure devices are so expensive that the only option you have is actually to just put your finger there and close it off. And because if you get to it when you feel the pulse, then you're good. But if you wait and you want to be very, everything is well, the angels are going to be speaking and they're going to take care of things. The problem is, once the hematoma forms above that vessel, you can't feel the pulse anymore. And whatever you're compressing, you are not compressing the vessel. So very importantly, don't wait until the crisis hits the fan. I want you to be able to catch this very early, very, very early before it. And the only way you can catch it is by checking very frequently, if it's every 10 minutes, every 15 minutes, whatever works, at least for the first 2 hours. That is key component here. For retroperitoneal hematoma, I think every ICU physician will know clearly how annoying this condition can be. And again, it can be very difficult to diagnose. Most times you need a CT abdomen to actually catch it, but the telltale signs will be there. Again, hemodynamic resuscitation, aggressive. Rarely, sometimes you might need to have a procedure to have the bleeding vessel closed off. Again, there are other things you worry about from a femoral side. We've had our fair shares of thrombectomies where after the thrombectomy, we have to call the vascular surgeons to go in and go open up a vessel, a thrombus in the distal profunda femoral artery. And more often you can have damage to the blood vessel, causing a pseudoaneurysm, which some thrombin injection will fix. And rarely, especially in patients who have a very long smoking history, have I seen some vasospasm. It does happen. And, a warm compress, it can be very helpful. So I think it's one thing to always have at the back of your mind. And in a lot of these cases, there's always some debate as to can we use anticoagulation, heparin, aspirin in some scenarios because of risk of bleeding. And if that's not a concern, then if there's a need for it, then please go ahead and do it. Groin pain is actually more common than it's thought about. So it's something to think of. I never thought I would ever see a femoral abscess, but I had one who came in about 2 or 3 weeks after I believe it was an AVM embolization and with sepsis. And I will own up and say I didn't discover the femoral abscess. It was actually my resident who took it upon himself to expose the patient, examine and looked, and then saw a indurate warm mass in the femoral groin, and we were like, no, that's not possible. It doesn't happen. And lo and behold, somebody we put in a scapular there and got a very nice welcome spewed of pus. So it does happen. So it is something to have at the back of your mind, maybe not immediately post-op, because I'm very sure that most of the surgeons here wash our hands and before we go into surgery, and we don't use the bathroom in the OR. So the other site that we use, access site, is radial access, which is becoming very popular, like I mentioned earlier. It makes life easier in a post-op management because you just have this wristwatch-like band that you put over the puncture site and you close it off. I haven't seen a lot of problems with that. I mean, there have been a few cases where there is some distal ischemia that subsequently goes away just because the hand is very heavily vascularized. More often than not, we always do the Allen test to make sure that the ulnar artery is there. And if you do have an ulnar artery, in most cases, everything does go well. But it is a growing thing. The challenge in the ICU care is just the general view that everything is fine, and somebody inadvertently takes off the transradial, or what we call the TR band, and you can imagine what happens. You now have a huge ball and blood is spewing all over the place, and it becomes a whole problem to manage. I would say I have not seen that happen. I've heard people talk about it, and I pray I never see one happen because the worst thing that you can do is to have somebody's hands get cut off. Then the other access point is direct carotid puncture. This is not very common. It's usually done in the setting of emergencies. I've done probably 2 cases where we couldn't get into the carotid artery from the aortic arch just because of the anatomy, and we had to go direct. Needless to say that was probably one of the scariest moments of my life in medicine, and it is quite the hassle. You are dealing with trying to get the thrombus out of the internal carotid artery, and then at the same time, you're dealing with bradycardia, hypotension. It's just a lot, and it is not something I will recommend. And the other problem is that once this patient comes out of the procedure, you also need to worry that their hemodynamic instability is persistent because you've messed with the baroreceptors or the carotid sinuses. You could have damaged the lower cranial nerve structure while burrowing this large catheter through the carotid. So it is also possible. More often than not, I've seen this more in most vascular surgery procedures where there's development of a hematoma that now compresses with the airway. Recently, their techniques have improved. I don't see it as much as I used to during the early phases of my career. But those are things that could also happen. Now, what happens when the patient hits the neuro ICU? And I think this is where I believe this lecture really wanted us to hammer on. The patient comes in, the groin site is fine, the radial site is great, and we are now saying, okay, how long is the patient going to be here? What are we looking for? And I think to a large extent, the approach we should take in this patient is the same level of hypersensitivity, hyper-awareness that we ascribe to neurosurgical patients. If you approach this any other way, you're absolutely going to lose 50% of your patients. And when you think about the neuro ICU, it is an environment where the mortality rate of all comers in the neuro ICU at best case scenarios is in the range of 30%. Once you start from there and then you become kind of lackadaisical, your mortality is going to go up very high. And the key component here is the early recognition. And how are we able to do that? What tools can we use to be able to identify when a problem is coming up? I always emphasize that you don't need to have what we always call state of the art. A clinically astute intensivist is probably way better than all the tools combined, because that is where you will capture the early signs. With the tools we have now, most times just give us a snapshot in time. We do not yet have truly dynamic tools that tells us fluctuations or changes or predictions of neurological deterioration. And very importantly, I have become very more sensitive to this topic, is that you have to be aware of the natural history of your disease. It can't just be all cookie cutter, everything fits a certain mold, everybody fits into a shoebox. You have to understand the natural history of the disease. You have to understand what physiology changes you anticipate or has happened or you worry that will happen. And you also have to decide, how does this brain respond compared to the other brain? A 50-year-old brain is different from a 90-year-old brain. It's the same token, a 50-year-old brain who has had multiple strokes in the past is different from a 70-year-old brain who has not had any stroke in the past or has no form of brain injury in the past. So again, your neurological exam is key. In our neuro ICU, one of the things we did when I joined Oshner for was it 12, 15 years ago, was we changed the what we call, the nurses became very involved in neurological exam. And we did, at the time, the Neurocritical Society developed this profile where the nurses could be involved and check neuro exams as frequently as possible, because we recognize very quickly that it's going to be difficult to have a resident checking a patient every hour or every 30 minutes or every 15 minutes. Well, believe it or not, manpower is expensive in the US. So if we can do that in Nigeria, trust me, that would be amazing. But the process to check the exam as often as possible and to track changes in that exam becomes a key component of your neuromonitoring tool. CT imaging or neuroimaging is helpful. ICP monitoring, very, very helpful. Believe it or not, hemodynamic changes tell you a lot about what happens if there are anticipated neurological injuries. Like I was talking about, the frequency is very important. We typically will start off with Q 15 minutes if there are heightened concern, and if there is stability over the course of the 2 to 6 hours, then we back off to every 30 minutes or every hour. But in the neuro ICU, by standard, every patient undergoes a neurological exam every hour. And our nurses are very well trained. The team is very well trained to look for subtle changes, subtle differences. And then where you as clinicians become very key, it become very important is making sure that you have neuroanatomical relevance to your exam. I once had a patient I had a resident who calls me and says, "Oh, this patient is not coughing, or this patient, is not moving the left hand." And I asked him and I said, why are you worried about the left hand? The patient has Guillain-Barré syndrome. So is that a new thing, or how is that relevant to the patient's neurological disease? How is it neuroanatomically relevant? And if you're not taking into consideration all those factors, then you can't make good decisions and decide what is the next best thing to do for this patient. And we have to be very sensitive to how we deploy resources, because I mean, these things are expensive. So it becomes very key that we're very thoughtful about how we use the tools that we use. And when we use them, we make sure that we understand the disease and how relevant they are anatomically in each setting. One thing that I've noticed is sedation is a big problem. There is a mindset that sedate patients so that they look comfortable and then you're comfortable. On the contrary, you want the opposite. If your patient is awake and kicking and fighting, then you're probably stopping them from getting better. I would actually advocate, and the Society of Critical Care Medicine in the US advocates, that we need to do more sedation holidays. A patient comes out of the operating room or from the IR, you want to at least wake them up. If they're still intubated, wake them up and find out, how are you doing? Are they awake? Are they responding? Are they looking around? If they're not doing any of these things, then there is a problem. Then you need to decide, is this still anesthetic, or is this a new change in their neurological disease? And if for any reason that you feel like they continue to stay that way, the solution should not be put them back on sedation and give them time. The solution should be hold the sedation. Don't continue the sedation because they have not responded. They have not responded and they're off sedation. There is a problem. And we need to keep trying to find out what that problem and continue to keep them off sedation. If they are not comfortable, they should wake up and tell me they're not comfortable. Otherwise, if they're not telling me they're not comfortable, we have a problem. The other things that we talk about using is imaging. I don't want to dwell too much on neuroimaging here, just because I know how expensive it is to get one scan, not to talk of series of scans. Before I left, I traveled, I had a patient who we were reviewing the quality measure, and we found that they had, in a space of 3 weeks, they had a total of 72 CT scans, including the head, the chest. I mean, every part of the body was imaged with CT. And it kind of brought up a question is, do we really need to do that? But at least one thing, there is a neurosurgeon at University of Washington who did this very beautiful study in TBI comparing neurological exam and at needed CT in TBI patients and outcomes. And what he demonstrated is that that neurological exam and which triggers a scan is way better than every other thing else, every other tool that is out there. So scans are great, they're wonderful, but we shouldn't, in an environment where it's kind of hard to get, we need to balance it out with our neurological exam as well. We use a lot of ICP monitors, hemodynamic monitoring, and it's kind of dependent on what the underlying disease process is. We'll talk a little bit about this as I go along and mention some specific conditions. I think nothing splits the neuroscience team as hemodynamic monitoring. The neurosurgeons want the blood pressure less than 140. We're like, no, that's not practical. We need it to be less than 180. And then it just goes all over the place. And even in the trials that have been done, the results are just all over the place. I mean, there's one trial that came out of China that looked at post-thrombectomies and blood pressure management. And when I looked at it, and I'm like, this is a reflection of the craziness that we just don't understand how hemodynamic fluctuations happen. And two, we are lumping patients who have different pathologies. You can't group a patient who has a cardioembolic stroke with somebody who has atherosclerotic disease. I mean, how those two patients respond in terms of hemodynamic changes varies. And my point here is, I believe the best approach in how we deal with this is to actually have a collaborative conversation. One, one perspective is usually not enough. Bringing two, three perspectives helps you to understand the disease process, the challenges. Like a classic example, I had one case where a patient went for an MMA embolization for a meningioma because it was highly vascularized. So went to the surgery, went for resection afterwards, came back to the neuro ICU. And I wasn't on call that night. They came in the following morning and all hell had broken loose because they were concerned that the kidneys were not doing well and the blood pressure was too low. And then they raised the blood pressure goals. And then the surgeon came in. I was upset. And then repeated a follow-up CT scan that shows evidence of some bleeding. And I was like, okay, what happened? Like, well, in the OR, we weren't able to cauterize easily. It was still oozing a lot. So we wanted the blood pressure lower. I mean, is there a direct relationship? I don't know, but clearly nobody talked to anybody. And that is my point, that if there is, we need to actually have more collaborative conversations so that we can understand the different perspectives of what each person's concerns are. And so that at least if something bad happens, then you know that we've done every possible thing from address from every possible angle for that particular disease. What do we use? More and more, there is a inclination towards using invasive hemodynamic monitoring, looking at maps, not just systolic blood pressures. There's been this new trend of trying to use transcranial Doppler ultrasounds. Hasn't really flown. I was part of a study that was trying to look at having this helmet that looked at flow patterns using TCDs, and it's a little bit cumbersome in the sense that the TCD equipment doesn't say the patient moves their head and then it gets thrown off. And you can't do CT perfusions on everybody. However, there are some principles that over the years that I've kind of developed. If for any reason you are worried about perfusion, then maybe your blood pressure should be on the higher side. If for any reason you're worried that the vessel is not going to be stable and it could rupture and can bleed, then maybe it's better to lean towards the lower side. Now, the problem is what is higher and what is lower. That's where everybody differs. If you ask me, I would say lower will be less than 140 because that's kind of within the normal range. But you have to remember that anything with a mean arterial pressure less than 65, then you're leading to ischemia. Number two is anything higher than 180, you start to see tissue damage. And that has been shown in multiple studies, especially in stroke studies, where once you start going outside of this range of 140, 180, then your risk starts to, you start to build a lot of risk. So again, 140 will be, if you want it lower, less than 140. If you want it higher, if you want to lean towards a higher pressure, then less than 180 is probably your safe bet, because you have to also remember as you go above 180, you're now also having cardiac impacts as well. Now, another bone of contention, and now this will capture a few of this in the case one or two cases we'll review. The use of anticoagulants and antiplatelets. So importantly, I actually underappreciated this significance until I actually went into fellowship. And in more than one case, I do recall seeing active thrombus forming in a stent, and it is terrifying. And it's so when a patient comes out of the neuro IR procedure and they are on antiplatelets, I would strongly advocate and suggest for the mental health of everybody involved. I think before we make changes to that, it's very important that we have a group conversation about it. And I would probably leave this conversation, this discussion more for the case that we'll review. Another thing to consider is we also have to weigh risk and benefit. There is no doubt that there is a case when there are times when we want to start, but it is risky. And there is no, and maybe beneficial in some cases, but risky in some other cases. But it's a very thoughtful conversation that needs to happen, and it should not be a case of, oh, just do this and you walk away. But it should be a case of, let us actually think about what we are trying to accomplish. What are the goals here? And we should tailor the decision to patients, to individual patient. Essentially, I'm promoting and preaching for the concept of a cheap man's precision medicine. Airway and respiratory, I touched on this a little bit. The needs and requirements are different in elective versus emergent neurointerventional surgeries. In elective cases, by default, most of these patients get extubated in the IR. Rarely will they be sent up to the ICU while or intubated. And sometimes when that happens, it's either because the patient was on too many sedation. And actually, in all honesty, when a patient comes up to me in the ICU and they are still intubated, I don't care what the anesthesiologist tells me or what the surgeon tells me. I just assume automatically that something bad happened. There was a concern and nobody wants to talk about it. And at that point, I call you into my office. We sit down, we make a cup of tea, and I ask you, be honest with me, what actually happened? And then the truth starts to come out that, oh, it took a little longer than we did. The patient is still paralyzed. We needed to paralyze it. And it's just things just happen. And you may just need a little bit more time for the patient to wake up and then come off the ventilator. But at the same time, it could be that they have bronchospasm, they have fluid overload, or there's a history of smoking, and they required a little bit more TLC to get them off the ventilator. So these things happen. Now, in the emergent cases, it becomes a little bit different. You have to think about the underlying disease. You also have to remember that some of these patients, when they come to you, they may have encountered some respiratory dysfunction. It could be aspiration, it could be, PE or whatever it may be. And the one thing that a lot of people forget is neurogenic pulmonary edema, because with acute brain injury, there could be dysfunction of the pulmonary vascular bed, and you have just pulmonary edema, and it just takes 24, 48 hours in most cases, and it gets better. The other thing I always think about in emergent cases is that the natural history of the disease. If I get a patient with a high-grade subarachnoid hemorrhage, I may not be too much in a rush to get them off the ventilator until I'm sure that they are heading in the right direction. And that is taking into consideration that I am anticipating the cerebral vasospasm down the road. Same thing with ischemic stroke. If I have a patient who has a left M1 occlusion, then I don't rush into extubating them unless you turn off sedation and they wake up, they're doing great, and everything seems to be working. Then I walk towards extubating them. So my point is that when you receive these patients from the neuro IR suite, you want to make sure you understand the underlying disease or the natural history of the disease in question that you're going to be managing. And for me, I almost always hold sedation once the patient comes out, unless the patient is paralyzed. The patient who was not paralyzed, or the patient still has paralytics on board, then I would hold off on sedation holidays. So let's go into some specifics in terms of for instance, we'll start with aneurysm embolization. So I am so blown away by the new techniques, devices that are coming up now in aneurysm embolization. When I was in residency, it wasn't this sophisticated. And now, I mean, it's looking like it's amazing. It's just mind-blowing. It's just a reflection of human ingenuity. So in the elective case, in most cases, the challenge isn't typically respiratory, isn't typically hemodynamic. Most of the time, it is more in thromboembolic events or hemorrhagic events that may or may not be related to the procedure itself. You have to remember that this stands, and sometimes if it is not, if a coil was not used, if it is not just a coil, stents when devices require utilization of an ample amount of heparin boluses, And more often than not, they require dual antiplatelet therapy, therapeutic dual antiplatelet therapy, which usually means aspirin and either clopidogrel or ticagrelor. I think that's the generic name. And these are very potent antiplatelet agents, and bleeding can happen. And very importantly, we need to make sure we avoid the mistake of holding antiplatelet therapies in these cases. If the patient just had a coil, then okay, maybe that is fine. We don't necessarily need to have them on continuous antiplatelets, although some people will argue against that depending on what papers you read. In the emergent case, and emergent setting, I mean, usually stenting isn't always the first line. Most people try to avoid it. I know someone in Rhode Island who who pipelined like multiple aneurysms after in an acute setting, and I was like, man, you have like really testicular fortitude. I give it to you. And this patient had an EVD, and with antiplatelets, with track hemorrhages. It's like, I don't know how you had the courage to do this, but kudos to you. So those are things you want to worry about. And I will use an example of a patient who, in my younger years, I was very stubborn and didn't have too much gray hair to show my suffering. And I started a patient who had an EVD on heparin sub-Q for DVT prophylaxis against the advice of my mentors. And guess what happened? Massive intraventricular hemorrhage, track hemorrhage, and luckily he survived, but I learned my lesson very quickly that sometimes it's good to take a step back and ask them some important questions before you start initiating things. There are other things you always worry about. Always assume that in the emergent cases, the patient is coming back to you. A procedure went well, everything went well, but I guarantee you the best assumption, assume the patient is not doing well. There are so many things that can happen. Patient can get to the ICU and become hypotensive. They can go into status epilepticus, acute kidney injury. So I always say, take from the head and go through every single system and organ and make an assessment. Whatever tools that you need or laboratory test that needs to be done, you go through every single one of them and then answer those questions. And importantly, I mean, talking about subarachnoid hemorrhage management is probably way out of the scope here, but vasospasm anticipation and with delayed cerebral ischemia is a problem. Status epilepticus is also a problem, which happens in about 20-25% of patients with subarachnoid hemorrhage. There's so many other things else that go wrong in this patient. So you have to be very aware. Again, patient comes in from the neuro IR suite, comes to the ICU, take every single system and ask the question, are you okay? Is everything functioning as I expect it to do? And if it's not, then you need to pull the trigger and shine the light on it to make sure that you can sort that out. AVM, dural fistula embolization. The two things I would say in this is if you are worried about hemorrhage, or if the patient has already bled, and they go for an embolization, then in most cases, what you worry about is the flow dynamics. Some more often than not, depending on where the embolization takes place, and if it is done in a way that, if you don't close off the outflow tract and you maintain the arterial flow, then you're worried that there might be what do you call it, bleeding. And if you've inadvertently close off a vessel that you're not supposed to, then you worry about cerebral ischemia. The one that I worry about that it doesn't happen so often, but I've seen a few of these, is you close off the part. Let's say there is an aneurysm, an associated aneurysm that ruptures, and you close off that part, and some crazy blood vessel from somewhere comes up, and you now develop this massive accelerated cerebral edema from hell. And it becomes a challenge. And unfortunately, we tend to miss it if we're not looking for it, if we're not thinking about it. And sometimes you keep the patient intubated and ventilated and sedated, sorry. So this is something to always keep at the back of your mind. And at the same time, I'll also suggest that talk to the surgeons or the proceduralists, have a team discussion to have a goal of what your hemodynamic goals should be. This patient should be monitored very, very closely in the ICU, including neuro assessment as quickly as you can, get them off sedation, get them off the ventilator if they are doing well. So that way, once they're off the ventilator, off sedation, you'll know if there are things going wrong in these patients. Carotid artery stenting is a unique circumstance. I bring this up. I know it's not something that we do a lot in Nigeria, but I bring this up for a couple of reasons. Number one is because whenever we access the brain through the carotid, not often, but it could happen that you muck around with a baroreceptor and the patient comes off with hemodynamic instability. And what that ends up meaning is that you have to put the patient on pressors, they're bradycardic. The problem is you can't always assume that's the issue. You also have to assume that other things could be causing this. So such as an MI could have happened. It could be shock. It could be sepsis. So it's very important that when you are dealing with this, the first thing that comes to mind, yes, you should think about it as a problem, but at the same time, you should also think about other things that can cause shock because it actually does look like shock. And you most likely need some liver fed for a couple of days, 2, 3 days sometimes, or even up to like a week for the patient to achieve new stability. The one other thing I really wanted to present is the cerebral hyperperfusion syndrome. And what this essentially talks about is if you're dealing with a narrow vessel and then all of a sudden you open up that vessel with a stent or with an angioplasty, and what ends up in the downstream is that you flood the downstream, and that downstream has been used to low blood flow, a low blood flow state. So when you flood it and the blood pressure is high, some of the smaller arterioles can rupture. And when they rupture, they can manifest as either hemorrhage or cerebral edema. And it carries quite a high mortality, up to like 40%. And which is why we, in these patients, end up staying in the ICU for a couple of days, and we try to keep their blood pressure less than 150. And that's been the standard across the board in most. Some people do less than 160, but the norm tends to be less than 150 milligram mercury. Again, do not stop their antiplatelet therapy. They need antiplatelet therapy. I think I would say again, mention collaborative discussion about the importance in the risk and benefit with the team is very critical. So let's talk about a few cases here, if I still have time. I know we started a little late, and let me know if I should hold off a bit. Should I go ahead? Or should I hold?
Yes.
Yeah,
Okay.
please do.
Right.
Yeah.
I just have two cases. So this is a patient I took care of. I think 4 years ago. Came in with a severe stenosis, 85%, had carotid artery stenting, admitted to the ICU for post-op care. Patient was hypotensive, responding to fluids, but now he required pressors. We examined him. He had right groin pain, and his pulses were not palpable in the right femoral. So when we see this, what comes to mind? So initially, obviously, you can say I separated the two. Initially, when they called us in the ICU, and we were like, oh, maybe it's just because of the carotid artery stenting. And I was on call that day, and yours truly decided to go home and let the patient come to the ICU. I said, oh, my residents can take care of it. And obviously, when he got to the ICU, crisis hit the fan, and then it was all hell broke loose. And then we discovered that he had non-palpable pulses. And if you remember, we talked about groin hematoma. And this is that, which is actually what the patient had. In his case, he had a femoral artery vein fistula, which had developed. The one thing that I didn't include in the case series that he was a smoker, so he had really bad atherosclerotic disease. So I think when they accessed, they may have punctured through the vein into the artery. And then obviously with that high pressure flow, it kind of ruptured and it kind of dissected all the way into the femoral, up the inguinal canal, inguinal ligament into the retroperitoneal space. So he had this massive retroperitoneal hematoma and groin hematoma. So when my resident calls me and he's like, "Oh, I can't feel the pulse," I was like, "What do you mean you can't feel the pulse? Put your finger there, put me on video." And I was looking at him and I could see the mound on top of his groin. I left my dinner, jumped into the car, came back, and we had to call the vascular surgeons to take him back to the IR suite. And the message here is that these patients can manifest with significant hemodynamic dysfunction and instability that requires most likely surgical intervention. And maybe if I had been around to notice that, then we could have probably prevented this or anticipated this problem and hopefully prevent it from getting worse. So it's something to always keep at the back of your mind. And in this case, he ended up going to the IR suite again. They used a cover stent to close off the fistula to stop the bleeding. And then we managed him supportively, and he did quite well, went home after about a week in the hospital post-procedure. And the second case, this is one that broke my heart a few months ago. 48-year-old female came in for an elective supraclinoid flow diverter stent. We did use a pipeline in this case, and she did wonderfully well. Woke up, she was extubated in the suite, cracking jokes with her, and then started her on aspirin and ticagrelor, which was stopped because she developed vaginal bleeding. And unfortunately, the ICU team did not let us know that the antithrombotics were stopped. 2 days later, she started complaining of a headache, which got worse from when we placed the stent. And obviously, somebody examined her and questioned if she had a left upper extremity drift, which at the time, in retrospect, I believe most likely was a reflection of distal ischemia. And then 4 days later, we finally kind of got wind of what was going on in terms of that they were consistently holding an antiplatelet against our advice, and got an angiogram that showed instant thrombosis. So we tried to open up we did what we could, which, I mean, this was terrifying, but really couldn't open it up. But the stents are subsequently closed off, and the patient ended up dying with a very large hemispheric stroke, a right MCS stroke, 21 days post procedure. And I think the message here, for me, at least I got it from that, is one is we need to be very sensitive to subtle changes, subtle neurological changes. We don't have an EKG to tell us there's an MI. What we have is our neurological skills, of neurological examination skills, and we need to really bear down on it. We need to take advantage of that. We also need to weigh risk and benefits when we have stents in the brain and we need to use antithrombotics. I don't think anybody has any patent to decision making. Collaborative decisions have been shown to be better than individual decisions. And I think to a large extent, if there is a question or if there are any concerns, do not hesitate to obtain neuroimaging. And so, I mean, what could we have done differently in this case? One is at the point when she had the concern for the vaginal bleeding, I think at that point, there could have been a much broader conversation, interdisciplinary conversation, and to weigh risk and benefits. Absolutely do not stop all antithrombotics. Maybe leave her on one, but don't stop the two. Number two is, if there were any concerns at that point about a change in our exam, well, no, we shouldn't have hesitated to get we should have hesitated to get a scan on her and do everything that we can to keep the stent open. Unfortunately, that's where things kind of fell apart, sadly to say. So I do think that the message across to the group today is think about neurointerventional surgery patients as your typical neurosurgical patients. Yes, they don't have their skull broken. They don't have a huge scar to their head. And, you know, it's very important that you think about them that way, because whatever is going to happen to them will happen to them with this, will happen to them in the context of acute brain injury. And we need to be able to keep acute brain injury at bay in these patients. The same sensitivities that we have, we need to astute them to that. A neurological exam is very, very, very important. Decision making should be collaborative. I will continue to preach that. It's been my mantra for the past 10 years. And at the same time, always weigh risk and benefits. And lastly, make sure you understand the natural history of the disease of the patient that you receive in the ICU. I will say thank you very much to Dr. Kafo for inviting me. And I see my Oga at the top, Professor Bankole. I think is he here? My partner in crime. I appreciate you all inviting me and having me speak with this glorious team. And it's been an absolute pleasure, and continue looking forward to working with you all. Thank you.
Thank you very much, Dr. Iwuchukwu, for that fantastic presentation. Is Prof. Bankole on the line?
Yes, I am. I just came in towards the end, and my network's been quite spotty, but I am. Yeah. Thank you, Dr. Iwuchukwu, for the presentation.
You're welcome, sir. I also see Professor Mejulo. I salute you, sir. If I'd known you, if I know all my guys would be here, for wear my suit and tie, you forget jet lag.
Obi, thank you very much. Thank you very much. Brilliant and beautiful presentation you've made there.
Thank you, sir.
Thank you. Thank you.
Prof, good afternoon. So, Prof. Bankole, please, if you want to acknowledge, we don't know all the people, the senior faculty from whom that are on the line, to just acknowledge them, please.
Okay, well, Professor JKC has already been acknowledged. He's the immediate past president of the Nigerian Academy and the current provost at the Nnamdi Azikiwe University College of Medicine. Professor Komolafe, I think this is Professor Mrs. Komolafe. She's the president of Nigerian Society of Neurological Sciences, the current president. Thank you very much for joining us, Ma. And other members of the audience, thank you all for joining us. My apologies for joining in late, but I think it's been the part I caught very interesting presentation, very practical, sharing lessons learned on the battlefield, for want of a better word. Yeah, so I think if there are questions, who is there? You can put your questions on the group chat, and we can also take questions directly.
Yeah. Do you want to stop sharing your slides so that you can now take questions?
Yeah. Let me stop share. There we go. Let's see. Do you want me to go take them one after the other? Well, where did it go to? Okay, so there is a question from Annie Kinsley, and it says, thank you for the presentation. Other routes eventually pass the carotid artery, so can't they similarly interfere with the baroreceptors? Well, the simple answer to that is that the vessel, the catheters that you're using to pass through the carotids tend to be way much smaller. You really don't want to occlude the carotid. So in that circumstance, not typically, but yes, it can happen, and which is why in most cases when we do a lot of these procedures where should I call it therapeutic procedures, we like to have somebody monitoring the patient because of these fluctuations that can happen. So in much younger patients where the vessels could be a little bit smaller, as you pass a large bore guide catheter into the carotid, you inadvertently can do that, especially at the carotid bulb. So it's not impossible. It can happen. So something you have to pay attention to. And then I see Chukwumamweze, what is the role of NIHS in the ICU post-intervention? Very good question. So this is my bias. I feel like the NIHS was designed for stroke care, and it has a very specific role and test model. It has become, because it's easy and simple and reproducible, most people have replicated it into other aspects of the neurological disease, which is fine, but it doesn't answer all the questions that you might need to answer. So for instance, if I do I want to think of an example. Depending on the location of where I treat a certain AVM or so, and NIHSS may not capture all the things that I want to monitor. So do you now depend on that, or do you wait for a problem to happen to tell you that there is something impending? That's my challenge with it. So, but is it frequently used? Yes, it is one of the tools that is used in the neuro ICU. There are other monitoring tools, clinical monitoring tools, or exam tools that are available out there that's been described. There's a guy called Elko Wijtix who designed a scoring system. He's out of what's the system? He's at the Mayo Clinic that designed a monitoring tool. He's one of the grandfathers of neurocritical care. Can you throw some light on I'm assuming that's post-op neuro ICU care of an aneurysm clipped patient? That's a whole textbook on its own. Or if you want me to sleep here, then I know they. But they are pretty much similar to some degree, with certain nuances. Some of the nuances, obviously, surgical site cares, other nuances are things like is it an elective or is it an emergent scenario? Where is the aneurysm? Where was it clipped? So for instance, if you're clipping an MCA bifurcation aneurysm, then I will definitely be paying attention to the territories in that region. So if it's on the right side, I'll be paying close attention to neglect symptoms and different features of neglect. On the left side, then I will not just say, how are you? Can you talk to me? I will narrow down on things like aphasia. So those things become very important in terms of what I focus on. And then the other thing that I look at in post-clipping is the access point. So this is where it's very, very key. And I really teach even the neurosurgery residents who pass through an ICU. One of the things I bang into their head is do not be too gung stuck on not talking to your team members. So a classic example, a patient goes in for a procedure, a lot of retraction was needed, right? And then the patient develops retraction edema. And then we are going crazy trying to figure out why are we dealing with cerebral edema, getting all these scans and what have you. So I come on service and I call the guy. I was like, dude, I need you to sit down and tell me what exactly happened. It's like, oh, we needed to retract. We needed to open this more. We needed to spread this more to visualize. I was like, why didn't you tell me this from the beginning? You will have saved me a whole nightmare. So these conversations become very important. And then sometimes you could see some hemorrhage that doesn't make any sense. And that could just be venous hemorrhage from retraction swelling. Those patients do really well. There is nothing to be worried about in those circumstances, unless obviously it starts to get bigger. So those are some nuances that are kind of different, but that's in most cases boils down to communications with the team. I see one, Alan Taylor, Margaret Opeyemi. Thank you. Shed more light on anticoagulation therapy post-intervention. Oh, you won't put me in trouble though. Well, There are several ongoing trials looking at anticoagulation in patients who have had intracranial hemorrhage. The challenge has been that every hemorrhage in each patient is distinctly different. A left basal ganglia hemorrhage in one patient is never the same. If it's not the same in the location, it's probably going to be different in volume. The patient's age is going to be different. The indication for the anticoagulation is also going to be different. So when you take all of these factors into consideration, you now see that the model that you will use to determine when to start is very complex. So this is what I do. I ask myself the question, what is likely going to kill the patient first? If the patient has a DVT and a PE, a pulmonary embolism, then I know very well that if this is a saddle PE, we're screwed if you don't do anything, because if you don't, that patient dies instantly. So in that circumstance, I'm like, you know what? I eat the consequences and start anticoagulation, despite knowing that they have an intracranial hemorrhage. But if the patient, for instance, has a relatively small DVT, deep vein thrombosis, no PE, looks fine, clinically, cardiorespiratory is fine, and I do know by default, they need anticoagulation, but it just had a 24-hour, 48-hour hemorrhage, then in that patient, I will hold off anticoagulation. And then when I say anticoagulation, I'm talking of full dose. I'm not talking of prophylaxis. I'm talking of full dose anticoagulation. I will hold off anticoagulation, and the teaching is your risk of bleeding or propagation of the thrombus starts to cross at about day 5 to day 7. And when I say cross, I mean risk of thrombus of getting worse, or risk of bleeding going, risk of thrombus getting worse starts to go up, and bleeding starts to come down at day 5 to 7. So at that point, I take an executive decision and say, okay, the risk is equipoise. We should start, or we should hold off a few more days. So that is typically how I go about this. This is just a very simple scenario. There's specific things to look out for post-MMA embolization in a patient who had recurrent subdural hematoma status post-evacuation. Not anything specific, not necessarily. The one thing that I have seen once was a fistula, an AV fistula, in one of those patients. I think a surgeon did an evacuation, the blood reaccumulated. I took the patient for an MMA embolization and did a run and saw a fistula. That could be something that might existed, which could have developed post-TBI or post-trauma. And that was something that I would say probably one should pay attention to after post-MMA. Otherwise, the procedure is relatively low risk. The only one thing that I will say we need to, and it's more on the proceduralist side, is more often than not, there are collateral flows to blood vessels that's up to the ophthalmic artery from the anterior ethmoidal as well as from the middle meningeal artery. So the patient might come back with the loss of vision in an eye. And if that happens, then you want to make sure you talk to the proceduralist so that they are aware of it. But more often than not, it's a relatively low risk procedure. Well, did I lose everyone? Anybody there?
We're here.
Oh, okay.
We
Sorry.
have you. Thank you very much. I think the last question was, you know the case you talked about, the femoral abscess? Femoral groin abscess.
Yes.
I've never heard of one. So
I know. I've only seen one. and
Actually,
I never thought it was possible. And I just came back 2 weeks afterwards and it was wow.
Interesting. And then just for the knowledge of everyone, we hardly give IV antibiotics when we do neurointervention, because anesthesiologist is always asking, what antibiotics do you give? We hardly give. Diagnostic, for intervention, we hardly ever give, except maybe we're doing like a kyphoplasty or vertebroplasty, then I would definitely give antibiotics and CEF for whatever you normally give your institution. So, but Dr. Martinez, who's one of our faculty here, is asking what closure device was used, do you know?
Oh, the one I use, they're a ton. They're quite a lot, not a lot now.
No, for that case, do you know they use a device?
They I think I don't remember which one it was. I think they used what's the one that's is it Perclose?
Okay, yeah, ProGlide, Proclose, ProGlide.
ProGlide, yeah, I think it was Perclose that they used.
All right, that's very interesting. That should be case reports because I've never come across it.
Yeah, I was so I just didn't think that it ever happened. And when the lady came to the ER, and because she had had a procedure 2 weeks ago, they automatically admitted her to the ICU. I was upset. I was like, why can't you just say it's sepsis? Take her to, and resident comes in, like I have this very anal resident who has OCD, and he decides to strip everybody open, and he examined her and just found a tender mass in her right femoral groin, and surgery came in, put a scapula in there, pop, and pus came out, and all of that went off. I did.
Thank God for your residents.
I'm telling
Time
you.
is gone. I don't want to keep anybody waiting. We have very busy neurosurgeons and colleagues who have joined us. Thank you very much. I'll hand over to, first of all, thank you very much again, Dr. Iwuchukwu, for a fantastic presentation.
Thank you so much.
I'll back it up to Professor Bankole to round us up. Thank you. Sorry, is Prof still here or? All right. I think he said his connection was not great. Okay. Thank you very much, everyone. Thanks for joining us. You can see posted is the next grand round, 8th of October. Please, let's put it on a calendar. It's been a very educational session. As they say, knowledge is power. I'm hoping that neurointervention will come to stay in Nigeria and will be practiced by our colleagues, radiologists, neurosurgeons, and neurologists back home in Nigeria. And we can get people to come and do training. We have very exciting faculty. Dr. Martinez is presenting next. She is a fantastic teacher, so please don't miss the next one. It's awesome. Henrik is one of our faculty too, who will be moderating, of course, Prof. Bankole, who's been our fantastic host. Thank you, everyone. Have a wonderful rest of your evening, your day, and morning, and God bless. Thank you.
All right. Bye, everyone.
Bye, Dr. Iwuchukwu. Thank you so much. The recording will be available on the website, so hopefully by the end of the day, Dr. George will have this posted on our